Hello, everyone. My name is David Bogumil, and welcome back to Lecture 4 now, where we're going to discuss and look at the applications of polygenic risk scores. This lecture is split up into three sections. We're going to first look at polygenic risk scores in disease prediction, and then we're going to discuss the use of polygenic risk scores in personalized medicine. And then finally, we are going to examine the use of polygenic risk scores in African populations. As, as with lecture 3, both on the bottom of the slides and in the notes too, you'll see occasional references to papers that discuss some of these concepts in more detail if you're interested. To start off, we're going to discuss polygenic risk scores in disease prediction. And there's quite a few things to think about when you want to apply a polygenic risk score to predict disease. The first thing is, at what level do you want to predict disease? Do you want to predict disease in a population? And common measurements for this are incidence rates and relative risks, where we're looking at predicting disease incidence, but not necessarily estimating the probability of disease occurrence in an individual, but more so trying to understand general patterns of disease incidence based on polygenic risk score within a sample or a population. And then what I think people more commonly think about, we also have disease prediction at the individual level, right, where we have an individual's polygenic risk score, and using that information, we want to calculate the probability of disease occurrence, given that simple polygenic risk score or polygenic risk score and other covariates too. So when thinking about this, it's important to ask the question why we want to even predict disease, right? What value does that have? And there's two main values to this. The first one is possibly altering screening protocols for cancer screening, and these may be screening protocols that already exist, such as, let's say colorectal cancer screening every 5 years for individuals over 50 years old, or prostate cancer screening or breast cancer screening. Or it could be the introduction of screening in among high polygenic risk individuals, where the screening didn't otherwise normally exist. And this might be types of screening, let's say for pancreatic cancer or things like that, where the screening might be a little bit more invasive. And the general goal of improving who we screen by incorporating information on polygenic risk scores is to get a shift in the staging, the cancer staging at diagnosis, right? Because it will be easier to treat the cancer diagnosed at an earlier stage, right? So if we get individuals who are of high polygenic risk and we increase the frequency of their screening, we're more likely to catch that cancer earlier when it's easier to act on. And then second major reason for predicting disease using polygenic risk scores is just to get population level information or public health estimates for disease occurrence. And this may be for most commonly discussed is public health interventions or interventions in healthcare systems for individuals who are at high risk. So, for example, if you have an individual who has very high polygenic risk and is likely to experience some type of cancer, let's say this individual might be a good choice to receive some type of support in lifestyle modification, let's say smoking cessation program, or in a clinical program for altering their diet, right? So it's important to keep in mind when evaluating a polygenic risk score and when predicting the disease, what the goal is and how well does the polygenic score work, and does it allow you to achieve these goals. And then we're also going to talk a little bit about current use of polygenic risk score um, in disease prediction later, but there is not currently widespread use in the clinical setting. However, it appears that we are slowly moving in that direction, especially as these scores and the methods improve. To recap a little bit of what we went over last time, again, we can just think generally, what is a polygenic risk score? And pretty much we're just getting these genetic variants that were identified in GWAS studies to be associated with disease risk, and we're kind of summing that information up in our sample and summing that information into a single score which best captures this kind of uh, pattern of genetic variation that is associated with disease risk. As you guys remember from the previous lecture, that once we have this polygenic risk score for our sample, we can look at the score as a histogram or a distribution and just see how people lie, right? We're going to have a small amount of very low risk individuals and a small amount of very high risk individuals, right? But for the most part, people kind of fall throughout the middle of this distribution. Now, when we're thinking about how to use the polygenic risk score in risk prediction, and this is before we're even calculating probabilities or anything like this, we're just descriptively looking at the polygenic risk score, it is important to consider, what will you do with individuals of the highest polygenic risk score, right? Are you going to select the top group and give them the lifestyle intervention, or are you going to give them the altered screening protocol? And that cut point with the polygenic risk score is determining what is a high or what is a low polygenic risk score and who receives or doesn't receive the intervention or treatment. That has a effect not only on the individual, but it has an effect on the cost too, to whoever is carrying out these types of interventions or altered screening protocols. So here, if we put a red line over our distribution, right? And we say everybody who has a polygenic risk score greater than this value are going to receive the altered screening protocol. Let's say instead of coming in every 5 years for their colonoscopy, they're at such high polygenic risk, we have them come in every 2 or 3 years for a colonoscopy with the goal of catching the colorectal cancer at an earlier stage. Again, we have to decide where this action kind of threshold lies. And these kind of lead us to think about how many people are we capturing who are destined to get the disease, and how many people are we potentially letting through and not giving the altered screening protocol who will get the disease but could have benefited from the altered screening. Here's another way of looking at that. So just like before, we have a distribution, but here what I did is I stratified it into two. We have the blue distribution, which represents the distribution of disease-free people, and then the red distribution, which represents the distribution of diseased people, right? And we have that same line as before, that same kind of action threshold line here, where everybody hot with a polygenic risk score value of this or higher receives the screening. But now we have this added information as to who actually will get the outcome, let's say it's cancer, and who won't. And you can see, on average, the polygenic risk score does something in that people with higher polygenic risk score are more likely to be one of these cases, which is like a circle with an X inside of it. And when we shift around this threshold, which is like our polygenic risk score, where if people have a value higher than it, we take action. You can see we do capture more of the cases, right, who could benefit from the altered screening protocol or the intervention. However, at the same time, we include a lot of disease-free people. And, giving these disease-free people who will never have the outcome the increased screening frequency or the intervention is costly not only to them possibly or whoever's supplying it, but in the case of, let's say, screening, the screening could be invasive and uncomfortable for the individual. So in that case, you might be needlessly applying that to a larger and larger group of people. As an example of that, here we can see, if we have our kind of threshold of action here shifted all the way down in order to ensure that, for the most part, we're going to apply the altered screening protocol, let's say, to such a large amount of people, right? Because we're allowing everybody with this low polygenic risk score or higher to receive the altered screening protocol, we will get all of the people who are destined to have the outcome, but at the same time, we are getting such a large portion of people who are not, right? And in this case, all of these people have to spend the time and money and possibly undergo the discomfort of more frequent screening procedures or undergo a lifestyle intervention that really wouldn't be beneficial to them. Now, when we have these different distributions of our cases and our non-cases, and we're kind of sliding around this threshold as to how to classify people, whether or not to take action or not, really what we're looking at is these measures of validity from epidemiology. You may have heard about sensitivity, specificity, predictive value positive, and predictive value negative, right? And it is important to have these statistics kind of tuned by altering where our kind of action cut point is in a way that considers the cost and discomfort and effort involved in an altered screening protocol or a intervention of some type. On the previous slide, we are just looking at the distribution of polygenic risk, the polygenic risk score calculated in our data set. We haven't even estimated probabilities or anything like that, but it is possible to use the polygenic risk score in a logistic regression model with or without additional variables. Here we have the additional variables of sex, age, and principal components, and this is just like our logistic regression that we use to assess how well the polygenic risk score performs, right? We have our sample and we have our outcome, right? Let's say colon cancer is our outcome here, and we fit a regression model with all these different variables, polygenic risk score included, and using this type of model, we can assess. We can do a few things. We can estimate the probability of the event occurring. We can estimate the incidence of the event occurring, and we can also just estimate the performance of the polygenic risk score in general, regardless of these individual level statistics. Because remember, we have our kind of population level statistics when we're assessing polygenic risk score performance, and we're looking at predicting disease, and then we have individual level statistics. So these regression models can be used for both. One way to use the regression model with the polygenic risk score term, as I showed in the previous slide, is just to fit a regression model with your outcome and the polygenic risk score term as a categorical variable. You can split it into 5 categories as we've done here, and get an understanding of how well the polygenic risk score stratifies individuals within your sample um, in terms of disease risk. And the results I'm showing you here are from a study that I did in the multi-ethnic cohort study, where we had a polygenic risk score with 31 genetic variants included, 31 SNPs, and we fit the polygenic risk score in a logistic regression model, just like as shown on the previous slide, and we look to see when that polygenic risk score, when we have it as a categorical term, where we kind of bin it into people into five separate groups, polygenic risk scores that lie between the 1st to 20th percentile, 20th to 40th, 40th to 60th, 60th to 80th, and 80th to 100. How much higher or lower is the disease risk of these individuals relative to the average? And the average here, remember, is the 40 to 60 group right here. So for this first panel up here is the combined multi-ethnic sample. So this is basically just pooled with all of these individuals. And here we can see the relative to the reference, how much higher the odds of pancreatic cancer is relative to kind of this average group here. So here we have a odds ratio of 1.33. So those in the 60th to 80th percentile group of the polygenic risk score, they have 1.33 times the odds of getting pancreatic cancer relative to those in the 40th to 60th percentile group. Now, this is more of a kind of population level statistic, a public health type of statistic, and not necessarily individual disease prediction, right? For estimation of risk for an individual, we commonly will use absolute or cumulative risk. And here I show results from an analysis we're doing in the multi-ethnic cohort study. And on the right, you can see the legend for polygenic risk score percentile, where we're basically looking at individuals at different percentiles of the polygenic risk score distribution. And we are seeing what is their cumulative or absolute risk of disease occurrence. Now, there's a lot of information in this figure, so we can break it down and look at a specific panel. So the columns correspond to the different self-reported racial ethnic groups in the multi-ethnic cohort. In the first one here, we see these are individuals who self-reported as Black at baseline when they enrolled in the study. And then on the y-axis of panels here, we can see we have panels for breast cancer in the first row, panels for colorectal cancer in the second, and panels for prostate cancer in the third. So if we were to look at this corner panel down here, the very first one, for Black individuals and prostate cancer, what this figure represents is the probability of an individual having prostate cancer by a given age based on their polygenic risk score. So let's interpret a specific value here. So for the polygenic risk score percentile of 50th percent, so this is kind of represents the middle of the polygenic risk score distribution, average person. By age 70 here, right, if we follow the line up to where it intersects with the green line, because that's what we're interested in, the average group, and then we follow it across, we can see that, let's say this is around 18%. So by age 70, an individual self-reported as Black is going to have a 18% chance of having had prostate cancer by that age, right? So, in other words, we're basically looking at close to a 1 in 5 chance of a black individual who is of average polygenic risk having will have experienced prostate cancer by age 70. Now, you can see with the other colors, right, with red and blue, that there's considerable risk stratification, right? So you can imagine the clinical setting, if somebody had a figure like this, and whether you're communicating to a patient or you're a clinician or policymaker, you could see how well the polygenic risk scores perform based on how much they stratify individuals. And then also, too, it can give you an idea of just how high the risk can be in some of these groups when they're at the upper end of the polygenic risk score distribution. Remember that the polygenic risk score distribution, right, has like a bell curve. So 50th percent is the average, right? And then in the upper tail here, we have 95%, right? The 95th percentile of the polygenic risk score distribution, that represents the blue lines. So here, at the same age as age 70, if we keep following this up to see, given that same age, what is the cumulative or absolute risk based on somebody's polygenic risk score for um, a 70-year-old, we can see that this is above 30%, right? We're approaching a 35% chance of having experienced prostate cancer by age 70 for individuals who are of this highest polygenic risk score. So on the previous slide, we saw these kind of relative risk estimates, which are frequently reported, but commonly, people are looking more into absolute risk estimates for health communication to individuals, but also to understand polygenic risk score performance and to communicate to people in policy and healthcare. We've kind of already talked a little bit about polygenic risk score use in personalized medicine, and I have a article in the referenced in the notes here that I recommend you guys take a look at. But currently there's very limited use of polygenic risk scores in the clinical setting, and there was a lot of hype around polygenic risk scores going back, like, I don't know, 10 plus years maybe. But as people have calculated these scores and assessed them and tried to get an idea of how they could be used in the clinical setting, it really has illustrated to researchers just how complex some of these diseases are and how difficult it can be to kind of sum up genetic risk into a single score. And we're going to take a look at this visually here. So for the application of a polygenic risk score in the clinic, again, going back to what I mentioned earlier, whether this is for an altered screening protocol or to select people for lifestyle intervention or something like that, how well the polygenic risk score model stratifies individuals is very important, right? If you have a polygenic risk score that is no better than flipping a coin to determine if somebody will get a disease or not, that polygenic risk score, of course, offers no value for altering somebody's screening protocol, let's say, right? But the closer and closer the polygenic risk score gets to perfectly separating out cases and non-cases, the more useful it can become in the clinic, and the more heavily we can weight that information for action in the clinical setting too. So here in this figure from the article I mentioned, we have two example models, Model A and Model B, right? And we have healthy individuals and diseased individuals. Diseased individuals are the people that fall outside of the diamond here. And the degree in which the polygenic risk score or the predictive model can stratify and separate out high and low risk individuals will determine how that score can be applied and used, or if it can be applied and used in the clinical setting. So, for example, Model B is better at capturing very high risk individuals, right, who would benefit more to more invasive prevention strategies, right? Strategies that you wouldn't want to give most of the population, whether it's costly or painful. Um, Again, in practice, in a lot of ways, we're not really there yet for implementing polygenic risk scores in this way, but theoretically, kind of this is what we are moving towards. And of course, individuals who are of lower risk, right? Here um, we can give less invasive um, action to, such as increased screening or just closer regular follow up or less invasive prevention strategies. One area which has received a lot of attention is the inclusion of polygenic risk scores in already developed risk scores for certain outcomes, such as breast cancer, for example. Now, we have these kind of non-genetic risk scores, which may include biomarkers and lifestyle variables and anthropometric measures. And recent research has been looking to see how inclusion of the polygenic risk score, in addition to this information, may help further stratify individuals and improve, right, risk stratification to where we can separate out even higher risk individuals for these type of targeted interventions or altered screening. As I mentioned earlier, one really important thing to consider when determining if a polygenic risk score should be used in an intervention or an altered screening protocol is this idea of an action threshold. And basically, this would correspond to either a polygenic risk score value or somebody's predicted risk based on a risk prediction model that uses a polygenic risk score. And really what we're trying to do here is determine at uh, what risk level do we intervene or apply an intervention or screening strategy to the individual. And of course, that not only is based on how well the polygenic risk score and polygenic risk score prediction model work, but it also depends on the cost and invasiveness of the prevention strategies too. Now, this is phenotype specific. Um, So, for example, certain deadly, let's say, outcomes it may be much more acceptable to take higher risk prevention strategies or more invasive prevention strategies. And this is kind of domain and phenotype specific as to what this action threshold would be. So you'd have to look kind of inside the field or the specific, phenotype as to what is accepted in that clinical community. Last, I want to briefly talk about the application of polygenic risk scores in African populations. And, a lot of what we're going to look at here really it can be relevant to the application of polygenic risk scores in any population. But generally, and again, I want to mention too, in the notes, I put two articles which discuss this in great detail. And if you guys are looking into applying polygenic risk scores in data you have, or you have ideas for the application in the clinic or something like that, I highly recommend looking into these to understand the caveats and limitations of applying these risk scores in different populations. But the first thing I would like to mention here is just the genetic similarity or dissimilarity between populations in which a polygenic risk score is developed and a population which the polygenic risk score is applied. Now, here we have a principal component graph, and this isn't based on real data at all. This is just an illustration from the article. On axis 1, we have PC1, axis 2, we have PC2, as we normally see this data graphed. And down here in the middle of the green circle, we have where all the arrows meet, the population in which the polygenic risk score was developed. Now, of course, as we've learned, there's many different stages in polygenic risk score development. This could be the identification of the risk variants that go into the polygenic risk score, and or the weights used in the weighting of the polygenic risk score. Now, if all of this information originates from European populations, right? The greater genetic distance we have between this kind of discovery or polygenic risk score creation population and the populations we want to apply the scores in, the greater the distance, the worse the polygenic risk score will perform, because of just the difference in genetic structure across the population. And this is captured in these principal component terms. We'll have another figure illustrating this in the next slide. And the reason why it's important to keep in mind, the similarity or dissimilarity between populations in which a polygenic risk score was created versus the population in which a polygenic risk score is evaluated, is because we need to keep in mind that, if we queried the polygenic risk score catalog, which is kind of like a catalog of a bunch of different polygenic risk scores for different phenotypes developed in different populations, we can see the vast majority, 88% of them, were developed or built in European populations, right, which have a different genetic structure, different linkage disequilibrium patterns than other populations. And what happens basically is the genetic variants which were identified to predict disease risk in, let's say, the European population, they may not necessarily predict disease risk the same in other populations, just due to varying linkage disequilibrium patterns. This is a very visual representation of what I'm talking about here, where we have on the x-axis down here different populations, and on the y-axis prediction accuracy. So for European, prediction accuracy is 1, because how they're calculating this value is basically, like how we discussed R square or AUC values being used as a measurement of how well a polygenic risk score can predict the outcome. Well, here what they're doing is they're kind of treating European as a reference. So let's say European individuals had an R square value of 0.65, right? That's the polygenic risk score performance for European, let's say. What they're doing is they're dividing that performance by itself to get 1, right? 0.65 divided by 0.65 equals 1. And then they're getting the polygenic risk score performance, the R square values, for all the other populations they're examining, and they're dividing it by European, kind of using European polygenic risk scores performance as a reference. And what happens here is we can see a drop off in the predictive ability of these polygenic risk scores um, across these different populations, right? So add mixed American, we get a slight drop, and this continues across these other populations as the genetic structure gets more and more different from the population which the polygenic risk score was developed on. Here they have UK, this is based on UK Biobank data, and here we have UK Biobank African ancestry, and you can see even within Africa, or African ancestry, there's considerable variation, and this is the case with the continent of Africa too, where there is considerable variation even within Africa. Africa is not, genetically a homogeneous um, continent itself, and we can see that reflected here in these results. So it's important to keep in mind that, if there's these already developed polygenic risk scores, which were created in the European population, you will likely observe a drop-off in performance when applying these polygenic risk scores and assessing their predictive ability in non-European samples. Just to go into a little bit more detail as to why this drop-off in performance occurs as the population's genetic similarity changes. Remember in the creation of the polygenic risk score, we have our actual causal SNP, where variation in that causal SNP results in a higher or lower disease risk. But frequently in our genome-wide association studies, we actually don't find that one. We will find some other SNP adjacent to it. They call this a tagging SNP. Now, for the most part, this is okay that we don't find the true causal SNP because it's nearby and they're strongly associated with each other. However, when we start trying to apply the polygenic risk scores in populations with differing genetic architecture, this association between the true causal SNP, which actually influences disease risk, and the SNP which we found in our GWAS study, that association is broken just due to the differing linkage disequilibrium patterns across the different populations. And this is what results in that kind of drop-off in performance we see. If we had all the true causal SNPs for a polygenic risk score, we would likely see very little, if any, drop off in the polygenic risk score performance across the populations.